everyone, welcome to my YouTube channel Pathology Learning. I am Dr. Monica. So in today's class, we'll be seeing about Marfan syndrome, which comes under an autosomal dominant disorder. So Marfan syndrome, as I mentioned, it is a autosomal dominant disorder. So any autosomal dominant disorder, we have already seen, it is going to have at least one parent who is going to be affected. It is going to affect all the generations, and then all genders are going to be affected in this, right? So this Marfan syndrome is actually a connective tissue disorder. So what is being defective here is that the gene which is defective in the Marfan syndrome is going to be the fibrillin-1 gene. So FBN1 gene, which is present on the 15q chromosome, is going to be defective in the Marfan syndrome. So this FBN1 gene is going to encode for fibrillin-1. Okay. So the pathogenesis of Marfan syndrome is going to revolve around this fibrillin-1. So if we see this fibrillin-1, it can cause two ways of pathogenesis. Firstly, it is going to form an abnormal fibrillin-1. Okay. So FBN1 mutations, usually there are about more than 1000 mutations encoding in this FBN1 gene itself. So the presentation of this Marfan syndrome is going to be quite variable. So heterogeneous kind of a presentation is going to be there. Some people will have some kind of expression. So variable expressivity, right? So that kind of a pattern is going to be seen in this Marfan syndrome again. And here it is mainly because of the various mutations which are present in the FBN1 gene itself. And most of the mutations usually are the missense kind of a mutation. So now let's see what happens because of this abnormal fibrillin-1 form which is being formed. Okay. So the abnormal fibrillin-1, what happens is that normally, if you see, the normal fibrillin is going to act as a scaffold for the tropoelastin. Okay. So on this scaffold only, the tropoelastin is going to form the elastin fibers. So elastin is again forming the connective tissue. So whenever this fibrillin is going to be defective, it is going to have a abnormal formation of elastin as well. So even though fibrillin is defective, elastin is finally getting affected. Okay, so that kind of a thing is going to be there. And what is important about this tropoelastin is that when elastic fibers are not being formed properly, it is going to cause various defects. Usually, elastin is going to be concentrated mainly in aorta, the vessel walls mainly, then in the ciliary zonules of the lens. So, ciliary zonules of the lens, they again have this elastin fibers, and then the joint ligaments. So, all of these are mainly composed of this elastin fibers. So, when this abnormal fibrillin is not able to form the proper elastin, so what happens? There is going to be defect in the aorta, ciliary zonules and the joint ligaments. So, this is what is going to lead to the clinical features of Marfan syndrome. Mainly in aorta, if you see, they are going to have aortic dissections. Ciliary zonules, you can have ectopia lentis, that is subluxation or the dislocation of the lens. Then in the joint ligaments, there is going to be laxity of the joints. So, these are the features which cause this present in the Marfan syndrome. Then, other than that, this fibrillin protein is also responsible for sequestering the TGF beta. So, transforming growth factor beta, it is going to be normally sequestered by the normal fibrillin. But because of the mutation, abnormal fibrillin is going to be formed, and this sequestration is not going to happen, right? So, when TGF beta is not being sequestered, it is going to result in excess activation of this TGF beta. So, when excess TGF beta activation is going to be there, it is going to result in other clinical features of the Marfan syndrome, especially the bone overgrowth, and also it can result in the vascular defects as well. Okay, valvular and the vascular defects can be seen in the because of this excess TGF beta activation. So, what actually happens is that this excess TGF beta, whenever they are present, they are going to activate the activity of the metallomatrix metalloproteinase enzymes. So, MMPs are matrix metalloproteinase enzymes. So, these MMPs usually cleave the extracellular matrix. So, when excess activation of these MMPs are going to be there, it is going to cleave the extracellular matrix and degrade the extracellular matrix. Other than that, this TGF beta activation is also going to affect the vascular smooth muscle development. So, when vascular smooth muscles development is being affected, that again can result in the vascular defects, right? So, this is the main pathogenesis of the Marfan syndrome. So, two things. Firstly, tropoelastin is not formed properly. Secondly, there is going to be excess TGF beta activation. So, do not confuse this with the FBN2 gene. So, FBN2 gene is going to encode for fibrillin-2. So this is going to be present on 5q gene. Okay, 15q was for Marfan's fibrillin 1. Fibrillin 2 is going to be present on the 5q gene and it is going to encode for fibrillin 2, and this mutation is again an autosomal dominant disorder causing congenital contractural arachnodactyly. So this is again an autosomal dominant disorder. So the gene for this is different from that of the Marfan's syndrome. So do not confuse that. So arachnodactyly, here again the patients are going to have long tapering fingers like that of a Marfan syndrome here. Okay. So this arachnodactyly is a skeletal deformity. So many skeletal abnormalities will be seen in this congenital contractural arachnodactyly. Okay. So now let's see about the clinical features of Marfan syndrome. So clinical features of Marfan syndrome, firstly, it is mainly going to affect the skeletal and the joints, skeletal system and the joints are going to be affected. So in the skeletal system, what is going to be there? The patient is going to be unusually tall, very tall, and then they'll have long extremities, very long extremities. Both the feet and the hands are going to be very long with long tapering fingers. And this long tapering fingers is the one which we call it as arachnodactyly. Okay. Apart from that, the head is also going to be long. Okay. So long headed. So that is, we call it as dolichocephalic. They'll also have frontal eminences. This supraorbital ridge and the frontal eminences are going to be quite prominent. So in the joints, we already saw the joints ligaments are going to be lax. So when the joint ligaments are lax, the joint is going to be hyperextensible. So hyperextensible means they can bend their joints unlike any normal person. So if this thumb joint is there, normally we cannot touch this thumb, touch the forearm with the thumb, right? But these patients can have hyperextensible joints, meaning their joints are very lax and this thumb can touch the forearm and then they can bend the knees forward like this also. Okay. So this kind of joint laxity leading to hyperextensible joints is a main feature of this Marfan syndrome. Then coming to eyes. So ocular defects, usually it is going to be bilateral subluxation of the lens. So subluxation means that it is dislocating. So the bilateral dislocation, both the eyes are going to have a dislocation of the lens, mainly because the ciliary zonules of the lens are going to be lax again. And the subluxation is usually outward and upward, meaning this way. Okay. So outward and upward subluxation of the lens is quite characteristic. Even it is the most characteristic feature of Marfan syndrome. So normally this bilateral subluxation of the lens, especially this outward and upward subluxation, is not so common. So whenever they find this finding, so they'll have to think about Marfan syndrome. So it is quite characteristic for Marfan's. Then coming to the cardiovascular manifestations. So cardiovascular manifestations are going to be the most important ones, being they are the most life-threatening ones as well. So in that, if you see, the most common one is going to be mitral valve prolapse. So 50% of the patients are going to develop this mitral valve prolapse, meaning it is a degenerative condition wherein the mitral valve is going to undergo some myxoid degeneration. Okay. So they become very soft and myxoid. Okay. So prolapse is going to be there. And apart from that, the patients also can develop mitral regurgitation. Since the valve has become very soft and billowy, so it becomes like a floppy valve. So when the valve is floppy, it is not quite competent. It cannot close the chambers properly. So that will result in mitral regurgitation. Not just mitral regurgitation, even tricuspid, aortic valves can also be affected. But mitral valve is the most commonly affected valve. Also, there is going to be vascular defects, right? So during the pathogenesis also we discussed. So in the vessel, if you see, the tunica media of the vessel is going to undergo cystic medial necrosis. So the media is going to undergo necrosis, which is going to cause the weakening of the vessel wall. So when this weakening of the vessel wall is there, it is going to result in aortic incompetence, especially the aorta, which is the ascending aorta and the root of the aorta, root of the starting point of the aorta. Okay, so the root of the aorta and the aortic valve ring. So that part is going to be affected in Marfan's mainly. So when the vessel is going to be defective, it can also lead to a very, very important and a dangerous condition called as aortic dissection. So what happens is that the vessel wall is going to be very thin and necrosed. So because of that, the gushing blood can cause the blood to dissect through the vessel wall. So when the vessel wall is being dissected by the blood, sometimes the vessel wall can be through and through dissected and the blood present inside the vessel lumen is going to come out of the vessel. That is going to be extravascular hemorrhage. So when aorta itself is breaking, it is going to cause massive hemorrhage and it is a very life-threatening condition. Immediately the patient can collapse. Okay. Classically, they present with severe backache which is progressing from the site of the dissection and it will descend down to where else the tear is going down. Okay. And finally, when the aorta is going to become incompetent, it can also lead to cardiac failure. Right. So usually we use the revised Gens criteria for diagnosing Marfan syndrome. Fibrillin 1 gene mutation, then family history if it is present or not, and based on the organs which are being involved, they are going to revise this criteria and they have given the criteria for diagnosing Marfan syndrome. So that's it for Marfan syndrome. So we'll be seeing about Ehlers-Danlos syndrome in the next video, which is again can have an autosomal dominant pattern of inheritance. Thank you once again. If you like my content, consider subscribing and sharing it to your friends who might also benefit from my videos.